Welcome back to Uncharted Narratives. Today I'm really excited to be hanging out with Kunal Parikh, someone who started in medicine and then made a bold move into health tech and aging advocacy. What I love about Kunal is that he's obsessed with impact at scale. He's asking hard questions about our healthcare system, about why caregivers are invisible, and about how technology can actually serve people instead of just being another buzzword. We're going to get into power dynamics in healthcare, the real story behind digital health, what it means to support caregivers, and why, as Kunal says, it's a game of persistence and their strength in numbers. If you care about where healthcare is going and how we can do better together,
So in 1980s, our healthcare model was very acute care centered. And in acute care, it's rather linear. You diagnose, you treat, and then you rehabilitate. That's it. End of story. With chronic care, there's so much more to it. You're trying to fit like a square through a round hole. It's not gonna fit. And that's what I mean. We designed a healthcare system at a time when it made sense, but we have failed to keep evolving the system as the needs of the people evolve. We're not being very transparent with the use of AI. It's getting increasingly more predictive and generative as well. But we don't know how it's making decisions. Ruth Bader Ginsburg, she had a mentor. She said, change minds first, then change the law. And I think that applies so beautifully to the way we're approaching change management in Canadian healthcare right now. Very official
Hi
looking.
Kunal, how is it going?
It's going really well. Thank you. It's a beautiful, snowy winter day. I love it.
Yeah, welcome back from India. I hope you are not getting more wet.
Honestly, it's always a transition going from plus 30 degrees to minus 30 degrees. So, just in the name of global climate, I guess.
Yeah, yeah. So Kunal, you have interesting career and experience. So every time we, as a one out of the practice, I know or I can predict if I am on the bedside or I am treating the patient where I will go. But your journey is a little bit is different. So you play different role and you are studied medicine by training, but right now you are more into not one things, too many of things. So what I want from you to let me know what lead you from clinical practice on India to pursue the path in health tech aging. Right now you are more focusing in aging advocacy and the system innovation in North America, specifically in Canada.
Thank you. That's a very generous introduction, Anas. You're right. I did begin my career as a physician. I trained and I practiced for 3 years in India. And 3 years was enough for me to realize that this is not what I want from the rest of my career. I essentially had no time to with my patients and their families because I was primarily in a gen surge capacity. And the reason I entered medicine, the reason I had that as my career choice was I love working with people. And I never got to do that as much as I wanted to. So I wanted to take a look at an alternative or a parallel career that helps me impact healthcare at scale. And I wanted to explore the role of technology in patient safety, healthcare quality, healthcare access. So I found this program at Algonquin College in Canada. It's called Digital Health. And I thought that's interesting. This could be like a really good segue into something else. So it was a 1 year program, very quick. And it didn't really go into the depth of anything, but it was a great 101 program to show me what all exists in healthcare technology, what are some recent advances, what does a Canadian healthcare system look like, and how can we implement a systems transformation or a technological lens and bring that into Canadian healthcare. And I was hooked. So, my first job out of that program was at a company that provided education and training to unpaid caregivers of older adults. And as a physician, I didn't really know as much about the social justice issues involving aging and caregiving, but that role at a startup really opened my eyes to these really critical challenges that exist in aging, be it ethical issues or equity issues. And I wanted to know more about that. So when I joined the company, I was the first employee. So the first day was kind of unique. It was the founder up here and me on the same desk on the right side. And it was great. Within 5 years, I learned a lot. The most important part being I really want to continue working with and for older adults through the rest of my career. No one's going to take me seriously until I have, credentials specifically in that area. So I went back to Queen's University to do my master's in aging and health, and mind blowing curriculum. It's such a good and well designed program. I learned a lot. And ever since then, I have been translating a lot of the research that I did, the capstones that I wrote, into thought leadership articles and videos and content that will ultimately change policy and the way we design interventions. As an example, my primary research was to explore the impact of virtual training programs on the self efficacy of caregivers. And I went in thinking, of course it will, right? Like it's a training program. Of course it will impact the self confidence and self efficacy. But that's not what I found. One of the key findings was caregivers don't even self identify as such. They think of themselves as a good son or a good daughter or a good husband. So I wanted to do more around increasing awareness of the distinct role of caregivers. And that led me to my TED talk last year on Did you know you are a caregiver? At the same time, the current interventions that we have are not cutting it. They're not enough to address caregiving needs. So I also created this framework called the Anatomy of the Ideal Caregiver Intervention. And I'm trying to socialize that so that we're able to create really good, well rounded, multi component interventions. Now, in July of last year, there was a mass layoff at the startup that I mentioned, Startup Life. The funding is so up and down. And after 3 months, I decided to go back to work at the Ottawa Hospital as an analyst. Now, I'm really fond of that role as well because it allows me to go back to my digital health roots. It allows all of us to work towards a goal of one patient, one medical record. It's honestly intuitive, right? Like, as a patient, if I go to one hospital in Eastern Ontario as opposed to another big hospital, I should be able to look at all of my health records in one place. But right now, that does not exist. Interoperability is a huge gap. And I get to work on that big project of the Atlas Alliance expansion, which is really, really exciting. And I teach at Algonquin College in the same program that I did when I came here as a student, which is a great sense of giving back. I learned so much from the program, and it's great to give back by teaching digital health generalists or strategists of the next generation. So that's kind of what I've
It's
been up
amazing.
to.
I don't want to cut you off. I'm see a lot of area here. We need to deep dive
Yeah.
in more specifically. Let's go back when you were in India and while you are studying in the school and you pursuing the medicine degree. That time, what you thought will be in the future? What is your specialty will be before you decided you will leave the medicine? What was your passion?
I genuinely thought I was going to be a surgeon for the rest of my life, maybe specialize a little more as one does as a general surgeon. But I was really convinced that surgical is my route. But, life had different plans. I didn't really enjoy um, that field as much. Also, because there's a certain aspect of paternalism in medicine, which I do not really relate to. It's almost like I'm the doctor, I'm the surgeon, and I'm going to tell you what's going to happen. Especially at that point of time in India, that was the pattern, that was a rhythm. And I don't relate to that. Believed, I believed back then, and I still believe in values of patient autonomy and family engagement, patient education, which did not receive the same level of priority as diagnostics and therapeutics. So that those are some of the reasons why the original dream of clinical
Yeah.
medicine or general surgeon didn't work out.
So yeah, so you were expecting your career to stay in the medicine and get involved in the medicine until you be specialized in general surgery, which is very respective role and especially within the medicine. But down the road, you came across multi-pump, which give you a time to check in is this is the right path or not. So in that time, you were still young and you see this is from different way. And I believe every student in the medicine and in the clinician, when they get in the system, they have this transition shock where they have the
Yeah.
hierarchy structure and they see the atmosphere and in the environment where that what was it they expected. They expected as a teamwork. They found a competition and this against the patient safety overall. But everyone, I'm considering everyone will be driven by ethics, principle, and moral like you. But
Hmm.
later on, down the road, they see why I put myself under the bus and start to advocate for the corrupted system or broken system. If I am a physician, I studied 7 to 10 years. It depends.
Hmm.
Is it not easy to fight and it's not easy to leave? So
Yeah.
this is a hard decision. Why I'm asking this question? Because I hear this a lot. I hear this
Hmm.
a lot. I am not feeling well being in this profession, not because I don't like it, because I like my patient and this is not what I thought.
Hmm.
As you and I believe also in India, correct me if I'm mistaken, the tradition there they appreciate the medicine and it's hard to leave the medicine after you study and start to practice. So how you manage this back in home and take this decision and this brave decision is not an easy.
You get exactly what I was thinking at the time. It felt like a big mistake at the time because, you're right. You did your nursing degree, you went through all of that training, and to kind of pivot from the conventional path, there should be a really good reason for it. There should be a really good plan or a safety net that you have. At a certain point, it was taking a huge toll on my mental health. I was not feeling like I'm doing justice to my own values and my own self by being a cog in the whole system. It felt like I was being untrue to my own self. And at some point, I just made a decision. You know what? I'm going to experiment with this alternative area. And if this does not work out, I can always return to being a clinician. That no one's taking my degree away. I can always practice medicine, but I really wanted to experiment with something that felt truer to what I want to do and my ethics and my principles. And also, something you said makes so much sense. When you go into medicine, in India, the system is you get into med school straight after high school. So after grade 12, you go through the competitive exams and you get into med school. No 16 or 17-year-old person should decide their career path. Like there should be a little more of a buffer or like a padding after that before you get into med school. Because when I went to med school, I had this naive idea of how the healthcare system would work and what I would be doing. And then you actually get into it. And by the time you realize this is very different than what I had imagined, it often is too late. So the only choice then remains, do I fight the system or do I continue just like propagating the paternalism and prescriptive nature of medicine? Or do I just carve out a completely different path? A lot of people said, you're an idiot. Why are you doing this? Why are you letting go of a perfectly cushy and comfortable life that you're going to have ahead and putting yourself in a situation with so much uncertainty? But it all came back to it didn't align with my principles. I really didn't feel like I was honoring myself.
I feel you because I've been in the same situation and be driven by principle, you will win yourself. There is certain people they need to do advocate and fight for this change. No one will take this.
Absolutely.
Physician and nurses they are very important to stay to serve the patient and try to treat them with the limited or certain resource, but someone will need to take bigger problem. And you have mentioned this in the school, the healthcare system not mention or not describe the existing and the actual, because there is gap between the curriculum and the actual environment outside. So then you decided to go more into innovation enhancement and go with the digital. You came here.
Anas,
Yeah.
actually, by the way, I just want to mention that when I was doing my training, my best friends for learning were the nurses because, the consultants will spend about an hour with you at most. But then at bedside, you'll have the nurses who are going to be like, you should look at that wound. It kind of smells funky. The nurses have so much more intellect and like roles and responsibilities than is recognized in the Indian healthcare system. I just wanted to say that right now I'm realizing that in hindsight, I learned way more from the nursing team than I did from my consultants. Like absolutely, without a doubt.
Yes, and I believe we had discussion in the past, and you have different perspective as a physician, because physician overall, with all respect, they came from the mentality or the system programmed them to have that mindset with the ego. I am the
Yes,
top and the other down. You mentioned the system developed or designed since the first war till now we are working in the same way. You were advocate to give more delegation from the physician, and this is something not need to do, and they need to delegate it for pharmacists, for nurses, because they can do it
absolutely.
better. So can you elaborate here more about this?
For sure. So my parents are I'd like to give some background. My parents are pharmacists. I practiced as a physician, and my sister is currently getting on to her practice as a psychologist. So, right now, I have the advantage of hindsight because you're right. There's a huge power dynamic with respect to physicians in India and to a large extent in Canada as well. There's an ego that this is the plan that I think is right, and all of the other healthcare providers should kind of follow suit. Like, be it a speech and language pathologist, or physiotherapists, or nurses, or psychologists,
Let's
everyone
put it in
else.
this way, Kunal, and let's be crystal clear. The system is patient centric, but right now we have physician centric. It's not a patient centric. So this is how it works.
It's a great way to put it because we like to think we're patient centered, but it's way more physician centered, what the physician actually thinks. So, the way I like to think about it is in Canada, the Canada Health Act was introduced in the 1980s. And at that time, it was a great endeavor because we're now providing universal health care to all Canadians. However, at that point in time, in 1984, we decided a list of medically necessary services. These are the services that will be provided to all Canadians free of cost. And these services can only be provided by physicians or nurse practitioners. And that's it. Over time, over the last 50 years, or 45 years, the lifespan has increased, number one. The chronic health conditions of people who are getting older have increased, and our healthcare needs no longer look the same as they did back in the 1980s. So in 1980s, our healthcare model was very acute care centered. And in acute care, it's rather linear. You diagnose, you treat, and then you rehabilitate. That's it. End of story. With chronic care, there's so much more to it. The point is not to cure, but to control and help patients and their families be better at self management of the condition. And none of those care needs are currently being met by these acute care models. So we're transposing an acute care model onto a chronic care need of the Canadians. And then we're like, oh, but why is it not working? It's because we're trying to fit like a square through a round hole. It's not gonna fit. And that's what I mean when I say we designed a healthcare system really well at a time when it made sense, but we have failed to keep evolving the system as the needs of the people evolve. And I think technology has a big role. I think systems transformation is going to play a big role, preventative care, long term care, all of those. So that's kind of where my mind's at with our healthcare system is rooted in the 1970s or 80s.
Yeah, sorry. That's right. And speaking on Canada, when you came to Canada to do your master in digital health, you decided to stay here and deploy your vision and mission here in Canada and try to work with the Canadian health system. So, can you tell me, everyone have different story, what the challenge you faced or have faced when you came to Canada, and you are not trying to work as a physician, so you are trying to work more into digital era, and for sure knowing the Canadian system there are a little bit limitation here and there. So what was your story in that time?
I'm going to be like completely honest. Money was a big problem. When I moved, I was doing the digital health program was a graduate certificate diploma at the time, by the way. But when I was studying, I wanted to, focus only on studying, and I don't want to work at the time because, I love academia. Within 6 months, I had exhausted all of my savings from India. So now I was like, well, now I need to work along with school, as everyone does. I was not doing anything unique. But when I was trying to look for a job, it was a terrible time because, I'm not going to be able to work as a physician right away. And I didn't want to, but even to work in a clinic or as a physician's assistant or anything close to healthcare was absolutely impossible. Like you could not even penetrate the first levels of interviews. Your resume is automatically rejected. And at the same time, I was like, okay, well, I still need to make some money. I don't mind working as a cashier at Walmart, for example. And, when you apply there, it's, oh, you're too overqualified. We don't want to hire you. And I understand that too. So, getting your first big break in Canadian healthcare as an internationally trained graduate is ridiculously and unnecessarily difficult. That was my biggest challenge. In hindsight, I'm glad that I didn't get any jobs at the time because the first job that I really started doing was as a PSW at the Ottawa Hospital. One thing led to another, led to another, led to another, and it was all meant to be. So I'm glad that nothing else worked out at the time, but it's very frustrating as an international medical graduate to not have any employment opportunities in Canada.
Yeah, and speaking in this, do you think part of the challenge we have it in the healthcare system not only is outdated, but only the way how they appreciate, there is no issue appreciate with the Canadian experience, but we overlook all the international experience. So we try to attract them to come to Canada. Then when they came to Canada, we say, no, 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 we don't your experience. I need you to be here in Canada. When you
Yeah.
start to work in the hospital, it's impossible. When you want to go for non-professional work or labor work morely, they told you you are overqualified. What is the confusion? I am overqualified in area and not qualified in other area.
Yeah. And that's exactly right. That's being addressed right now by a lot of unions that work with personal support workers. This is a massive trend, by the way. Like we're getting people from the Philippines, from other third world countries to migrate to Canada because we have tremendous care needs. We don't have healthcare workers to fulfill those needs. So we are helping people migrate to Canada and we're leaving them to fend for their own. So there's work being done to help with immigration pathways and skills training and language training and acclimatization to the Canadian climate and everything that is being worked on right now so that there's a clear path to employment opportunities as well as immigration. Both of those need to go hand in hand. And, someone might think, well, but what does immigration have to do with employment? Everything, absolutely everything. If someone is choosing to uproot their lives and move to Canada to help the Canadian healthcare system, the very least that they should have is a safety net or like mental security that my immigration process is going to be smooth since I'm putting in so much critical work towards the Canadian healthcare system. So both of those go hand in hand.
Yeah, and it's came to my mind right now. Canada intended to be a country for all immigrants, so they
Hmm.
believe in equity and diversity. However, there is no fairness on employment. Compared to our neighbor, us, it's big market, very competitive, and to come to us, they not culture friendly like Canadian. But
Hmm.
you will get access to the workforce much faster compared with the Canada. So any nurses and physician, if they want to move to the US, they have a clear pathway to get
Hmm.
into their profession.
Right.
And this is way faster compared with the Canadian. However, in Canada, this is take a very lengthy process and slower. And Canada, they promote themselves, they are welcoming and they want everyone
Yeah.
to come. There, they are not, but still, you can find the
Hmm.
opportunity. That's what I meant to put it in.
And also, as an international medical graduate, even if I choose to go through like all of my licensure, I would have to redo residency. And the residency spots in Canada in general are way less than the States. And at the same time, the number of spots for internationally trained doctors to apply for residency are like a very small portion of that very small number of total spots. So it's almost impossible right now for an international medical graduate to go to residency in Canada. Things are evolving and things will change in the future, but that's just a snapshot of what's happening right now.
I hope so. This is disheartening to lose all those talent. So let's move for something more about the healthcare infrastructure and workflow. We believe still it is outdated and needs more enhancement and development. So, what is the realities right now? You believe, based on our population, is infrastructure or workflow still outdated, and we need to spot them immediately?
Great question. I think we're getting a lot better as a healthcare system at being patient centered. I agree, we're definitely physician centered always, but we're now at least recognizing the importance of patient centricity. I think that's inadequate. I think that's colossally untrue or like impossible to, because I think we should be more dyad centric, where the dyad represents the patient or the person as well as their caregivers, because we're not making, if I'm a patient, if I have a certain chronic health condition and I'm managing it myself, I'm still getting help from my family members. I'm still making a lot of healthcare decisions along with my family members. It's inadequate to just support me. I need the healthcare system to also support my caregivers, because at some point they're also going to get tired of supporting me. So there should be dedicated caregiver support as well. So it's almost insufficient to just be patient centered. And while we're going through this transformation phase, it would be awesome if we could move from patient centered to more dyad centered. And you know what? That also makes me think, we keep saying patient centered. I would love to just call it person centered or client centered. Let me ask you a question. How do you define a patient?
Anyone need care?
Okay. However, I'm going to challenge that. So let's say I'm pregnant and I need to go to the hospital to get my ultrasound. So I'm using healthcare services and I need care. Does that make me a patient?
That mean not necessarily to be a sick.
There you go. It's to go. We've got like this sickness care system and we need to transition it to like a real health care system. There's so many examples like that. A pregnant person accessing ultrasound services, me undergoing colon cancer screening, or me using like a 23andMe kit to do DNA analysis or like genealogy. All of us, all of these represent utilization of healthcare services, but that does not make us a patient. So moving towards a little more of a consumerism mindset in healthcare is beneficial. Not all the way consumerist, because that has problems of its own, but I think we still need uh, to adopt that lens of consumerism in healthcare to reinstate autonomy and the power back to patients and their families, where it's at a point that I'm getting healthcare services and I'm entitled to a certain level of quality and dignity. And these are my priorities with my care. And I want those to be met. It's not just what the physician thinks or what the healthcare team thinks. I shouldn't have to accept that passively. I should be a more active team member in my own care plan. And I think consumerism is one way that can help nudge us in that direction.
So the patient need to be part from this, from treatment plan, and take the decision in this, so they can
Absolutely.
meet together. So what do you think is the strength in the Canadian healthcare system?
The universality of Canadian healthcare system is definitely one of the biggest trends. There's real power in being able to say that no matter who needs healthcare services or any kind of treatment across Canada, they will be able to receive it. That is absolutely fantastic. That's a huge plus point or an advantage of the Canadian healthcare system. Having said that, how truly is the Canadian healthcare system universal? At this point, 22% uh, Ontarians do not have access to a family doctor. They don't have someone that they can go to for continuity of care. So if they have a healthcare need, even if it's something like, oh, I have strep throat and I need antibiotics, that's not an emergency. But if I don't have a family physician, I have two options. One is I go to an apple tree clinic where the wait time could be, 3-4 hours during the day, so I'll be missing a day of work and I'll go to Apple Tree and I'll get my treatment. Or the second option is I go to the emergency department and spend 12 hours because it's not an emergency. So they're not going to prioritize me, rightfully so. But that's how I'll get my antibiotics. So that's what's happening right now. So, how truly universal is the healthcare system? People need to go to like these extreme lengths to be able to access
Mm,
basic
mm.
healthcare services.
So where do you think Canadian system most need transformation for more modern approach and greater accessibility? So speaking on having access for the system, it's nightmare. Or where more support innovation we can do for the healthcare system?
So there's two sides of the coin. One is unrestricted access, which is basically every single Canadian, regardless of which province they live in, have a family physician assigned to them. That means that me and my whole family can have the same family physician. We can talk about care plans. We can talk about, what we discussed last time, how this medication has been doing, what are the side effects? Oh, let's change it. So there's continuity in care. So, and that is unrestricted access. That's one end of the coin. The other end of the coin is depth of coverage, which is right now, vision, dental, these are not things that are covered by the provincial healthcare systems because apparently eyes and teeth don't matter. They're not a part of your body. So at some point, we need to have a higher depth of the services that are provided or that are covered by the provincial healthcare system. So the tension then always remains, should we prioritize the unrestricted access or the depth of coverage? And that's an answer that's impossible to determine. They're not really competitive or like conflicting in nature, they're complementary. But in order to do anything in that realm, we need to have a complete systems transformation lens. We need to invest in more preventative care, primary care, and even long term care sectors because let's face it, no one wants to go to a hospital unless they absolutely have to. So let's move care closer to people's home. So innovation that could help with aging in place, something that helps with mental health resources that are universally available. Something even as basic as sexually transmitted infections testing in an anonymous way in the community, which is being done to a large extent right now. But stuff like that, that's where the real innovation lies. And there's a certain fallacy in thinking that innovation has to mean invention. Like innovation should mean like a VR headset or, like these sensors or smart homes. Innovation does not always mean invention. It could be like a new workflow or a new way of doing things or a new funding model or a new service delivery champion. Innovation is all of those things. And that is where we need to focus our efforts right now. There's also big value in revising or revisiting the role of all levels of government in our healthcare system. Right now, the general perception is healthcare is a provincial responsibility, and that's it. The federal and the municipal governments kind of get like a a clean sheet with that. But there is massive role of all three governments. There's huge sums of money being transferred from the federal government to the provinces in terms of transfer payment agreements. This should come with strings attached. This should be associated with outcomes, like how many health outcomes, how many people have been treated, or how many people have been able to be served by the healthcare system. All of that should be included in accountability mechanisms by the feds towards the provinces. The provincial government obviously is managing a large share of the healthcare delivery in terms of hospitals and the direction and the leadership that they set for the hospitals and points of care. But then there's the municipal level. Most of the public health interventions can be managed at a municipal level. Simple example, breastfeeding clinics can solve a lot of lactation problems. Sonography clinics can help with uh, uh, they can help with a lot of prenatal care and even postnatal care to a large extent. The point is, we need to hold each level of government responsible for what they can actually do. Just saying that healthcare is a provincial responsibility is such a tired and worn out excuse that we should not just accept right now.
You are very well. So the hierarchy structure from federal to provincial to municipal, they have a clear role for them, but still there is a cross point that they can work together and there is overlap. But it seems like now they are working on the silos and they
Hmm.
are not connecting together, which make this gap. So I want to ask you from international educated perspective because we discussed that. How
Hmm.
does working in multiple countries can improve the patient care and system design and caregiver here in Canada?
I feel like all countries and all healthcare systems have unique advantages of their own. As an example, in India, if I have a knee replacement surgery, for example, I can get a consult tonight. I can get scheduled for surgery if everything checks out next week, and I can have rehab, and that's it. In Canada, we wait for like 18 months to 2 years. I think that was true during the COVID-19 pandemic. It might have reduced a little bit, but it's still a big problem. At the same time, patient privacy and confidentiality is a huge problem in India. There's not as much attention to data security and patient confidentiality. So I think those are some of the differences that are going to exist. And since we're envisioning and conceptualizing like an ideal healthcare system, we should try and pick the positives and the unique strengths of all healthcare systems and kind of bring it together, because ultimately that's going to be the recipe for success.
Absolutely, yeah. It's good to see the success story in other country, like anywhere, like in Europe, in Denmark, and those happiest country in worldwide, and see where they did a great job and try to
Yeah,
take this lesson from them and try not to take it as is to our country, try to customize it and tailor it to fit for Canadian system. Speaking on that, could you touch base about the innovation and the innovation not necessarily to bring something new or innovative? It's about create a new way to do the same thing in much efficient and faster, whatever way. That's the
there you
way how
go.
we can looking for innovation. But right now there is the hype and the trend. Everyone speak about technology and specifically in AI.
Mm.
So speaking on AI, and you are more advocate and specialize in aging in Canada. How do you see this technology could help this in particular uh, a population and aging population in Canada? And what should the policymaker and the clinician focus about this?
So we cannot go 1 minute talking about age tech without talking about AI as well. So AI is here and we are using it. All of that is good. But I feel like there's a temporal mismatch. So AI is moving at like this speed. It's so fast and there's new interventions, there's new innovations that are coming out every few months. And all of that is great. However, human adaptation takes a lot more time. It's the speed at which we can adapt our mindsets to the use of AI is it's not as fast as how fast AI is moving at innovation. There's also these older adults did not grow up with the same churn of interfaces that a 20-year-old goes through right now. So learning new technology for them is going to have a learning curve. So as innovators and developers, we need to make sure that that learning curve is a lot smoother and we're helping them get on with it. And at the same time, there's so many mixed messages about AI right now. Like there's older adults are disproportionately affected through scams and elder abuse, financial risks, and and now they're hearing mixed messages about what is AI safe, is it biased, so on and so forth. So they don't know what to trust and what to stay away from. So yes, AI is moving so fast, but at the same time the speed or the velocity of human adaptation and adoption is not as high. So we need to be mindful that we need to give people enough time and help them adapt to the new interventions that are coming up. And that's only from the human side of things. If you think about the system perspective, the healthcare system moves at a glacial pace. The healthcare system will incentivize and will fund interventions based on their historical performance. And historically, we have used acute care models. So the new interventions of right now, which help with chronic healthcare, are not getting as much priority. And that's just a challenge. So one of the things that we need to continue doing is pushing and advocating for meeting the chronic health needs of Canadians right now and the use of technology in an ethical and equitable way in order to do so. Unless we have this dialogue constantly, we're not going to get there. As another example, the childcare tax benefit um, was launched in 2015. But there was many, many years of lobbying and advocacy for the childcare benefit before it actually went live. So when we think about caregiver tax benefits or caregiver stipends, we need to keep having those dialogues and conversations right now so that it potentially might come true or go live in, I don't know, 2030. Let's be ambitious. Let's say 2030. So we need to keep having these conversations. I'm also going to say this. We're not being very transparent with the use of AI. AI is this like interface or a screen that is getting increasingly more predictive and generative as well, but we don't know how it's making decisions. The way I explain this to my students is the concept of a black box is I go to a vending machine and I select like I want a Kit Kat, and it just I pay and it gives me a Kit Kat automatically. Sometimes it makes a mistake and sometimes it pushes out items. So I don't know, standing outside of that vending machine, what's happening inside of it. And that's how AI is right now. It's kind of hitting most of the time, but at times it's making mistakes. And the lack of transparency in how it is making those decisions is really its own impediment, is really deterring people from believing in it and having trust in its safety and efficacy. So we need more transparency in the use of AI in age tech interventions.
Yes, and I believe still hospital they are not ready for AI for different reasons. Not only for the resistance from the healthcare provider and the patient, also the healthcare as part from my job. They failed every time to make any change. They don't follow the
Yeah.
change management process. So for any technology in the past, they use it. Implementing a new software is take from them ages, and sometimes they bring the best solution ever, but they fail to implement it because they don't
Yeah.
follow the right way to do it. So it's not to follow the trend or the hype, how much we are willing to see what is required for us and how we can adapt it for our solution. So no doubt about the AI, and the AI, especially in the medical field, need to be more trained and need to be compliance with all accreditation and regulatory bodies. It depends where they are.
Yeah.
It's something we need to highlight it for there. So closing here, Kunal, I can speak more and more with you, but I would like to get your advice for any newcomer or No, no, not all. I need your advice for a newcomer who are planning or they are in Canada, and anyone in career transition or changing, and they are in doubt if this is the right thing to do or not. So, what is your advice?
So I already gave you the bad news, which is it's really difficult as a newcomer, internationally trained medical graduate to penetrate the Canadian healthcare system. It's very difficult. We talked about that. But the good news is we're at this point of massive change and massive transformation in how we're even defining healthcare. So, healthcare is not just limited to the hospitals, it's expanding to social services, community care, preventative care. And a lot of that will require people who have some background or some expertise in healthcare. So I would almost advocate, as I do with my digital health students, invest in building skills that are not clinical as well. As an example, yes, you have, background as a physiotherapist, but it wouldn't hurt to also get some certifications in product management or project management, change management. That's such a big one. And those will position you so much better than others who are applying for those kind of positions who don't have a healthcare background. The digital health transformation has been going on for a few years, but it's nowhere near done. There's a lot more work to be done. So there's enough work, but you want to make sure that you're building skills in non-clinical areas as well. And it's a game of persistence. There's gonna be like 100 no's before there's the one yes that changes everything. So as cliche as it sounds, persistence is genuinely the key. If someone would have said this to me when I was looking for a job, trying to, make ends meet after my savings ran out, I would have yelled at them. So I get that this is sounding cliche, but honestly, it is the path forward.
Absolutely. Good advice. So, what keep you motivated and inspired about the future?
I'm cautiously optimistic about how fast the change is happening right now. A few years ago, even just 5 years ago, support did not receive as much attention. And right now, we're talking about caregiver training and peer support groups and respite care. So the change is happening. It's happening really fast. One thing, why it makes me cautiously optimistic is there's still human mindsets and human adaptation will take time. Like changing human mindsets is a long and arduous process. So we need to constantly keep talking about these same things and pushing for the very interventions that will make aging and caregiving easier going forward for us to get those supports from the system. So Ruth Bader Ginsburg, she had a mentor, Dorothy Kenyon. So it's like Ruth Bader Ginsburg, God, Darcy Kenyon, God of the gods. She said, change minds first, then change the law. And I think that applies so beautifully to the way we're approaching change management in Canadian healthcare right now, trying to impose these new technologies and these new innovations onto people without having changed minds first. So it is our responsibility to keep the pulse on this conversation alive and advocate for better supports and better services for.
And this is the last question, but this should be the first question for you. How you positioning yourself on the social media? Who
Oh
you
wow,
are?
that's okay. So this is a very interesting question. I would think of myself as an aging and health advocate because at the end of the day, all of us want good health and to be able to age in a good world. Whatever that process means to you, I hope you get that aging process. I think of myself as a knowledge mobilizer because I've gathered and accumulated a lot of expertise and now I'm trying to like use those insights to help design better interventions. And at the same time, it's all about community for me. I'm a community builder, man, or like a community enhancer. I love working with people. And I truly believe that to go far, we're going to have to go as a mass. So I love to get people who think similarly together and push for the same things because I strength in numbers.
Encourage you to keep doing what you are doing and build this community and advocate about the system and aging in group and population. And you have all the skill set and the passion and the aspiration to do that. Kunal, it's
Anas, I'm a part of the community. You're building the community. You're the one building it.
you are so
Thank
humble.
you.
You are so humble. Thank you for your time. I really appreciate giving me the time to sit with you and discuss about your journey, a role model for the success, a
You're
physician
too
and a
kind.
newcomer. Thank you, Colonel, for you.
Thank you so much, Anas. Have a good
Thank
day.
you. Bye bye.
If this episode sparked something in you, here's how you can keep our mission alive. Subscribe to Uncharted Narratives Surdiyat. Leave us a 5-star review. It helps more amazing people discover our stories. Share an episode that moved you with a colleague or friend. Connect with me on LinkedIn and join our healthcare innovation community. Together, we're not just telling stories. Until next time, stay curious, stay passionate, and keep pushing the boundaries of what's possible in healthcare. See you in the next episode of Uncharted Narratives Sardiyat.